evening, everyone. It's my absolute pleasure to welcome you all to the ELSACON pre-conference webinar. On behalf of the organizing committee, I extend my warmest greetings to our esteemed faculty and all the distinguished delegates who have joined us from various parts of the country and beyond. ELSACON is a platform dedicated to fostering knowledge, collaboration, and innovation in extracorporeal life support and advanced critical care. This webinar is a testament to our commitment to continuous learning and the pursuit of excellence in patient care. So the agenda for today's session focuses on the physics and physiology of ECLS. These sessions form the pre-conference series conducted over 2 days, that is today and tomorrow, designed to cover all the theoretical aspects of the ECMO before the live hands-on workshop at the physical conference. This structured approach ensures that all delegates gain a strong foundational understanding before participating in practical sessions. We encourage you to take full advantage of these sessions, ask questions, and actively participate in this enriching learning experience. We are honored to have an exceptional lineup of speakers, both national and international, who will share their expertise, experiences, and latest research, enriching our collective perspective on critical care and extracorporeal support systems. A huge thank you to all our speakers and organizers who have worked tirelessly to make this webinar possible. Your dedication drives the success of ELSACON, and we are truly grateful for all your efforts. With that, I officially welcome you to the ELSACON webinar 2025. Let's embark on an engaging and enlightening journey together. So now I hand over the session to Dr. Ramesh, one of our team members from Apollo Hospitals, Jubilee Hills, who will be hosting today's session. Thank you all, and let's begin.
Thank you very much, ma'am. Good evening, everyone. It's a warm welcome to ELSACON 2025. It's my pleasure to introduce our first speaker, Dr. Balasubrahmanyam, sir. He is a top critical care specialist in India, having 14 years of experience in critical care medicine. Currently serving as the senior consultant in critical care medicine in Citizen Hospital in Hyderabad. Dr. Balasubrahmanyam sir have made significant contribution to the field, having published several papers and delivered professional talks to the renowned scientific forums, including national and international conference like Critic 2021, EuroAsia 2017 in Hong Kong, and the National ECMO Conference in Chennai also. Sir, area of interest in invasive hemodynamic monitoring, complex mechanical ventilation, ECMO, end of life care, nutrition, acute kidney injury. Please join me in welcoming Dr. Balasubrahmanyam, sir.
Good evening. At the outset, I'd like to thank Dr. Niranjan Panigrahi and the entire ELSACON team for giving me this opportunity and wish them a great grand success of the conference. Let me start with the topic, extra and intracorporeal circulatory interactions and ECMO response. I'll be dealing with some amount of basic oxygen kinetics. Then we'll go with the circuit and how it gets interacted with the intracorporeal circulation and what we should know as an ECMO clinicians. We all in the first year of physiology, we know that oxygen delivery is nothing but cardiac output into arterial oxygen content. Cardiac output in place of ECMO is nothing but ECMO flow plus native flow. And arterial oxygen content is 1.34 times your hemoglobin and arterial saturation plus the dissolved oxygen. Whereas oxygen consumption is cardiac output into arterial oxygen content minus venous oxygen content. In a normal patient, we know that arterial oxygen content is about 20 cc per deciliter with a normal hemoglobin and a flow of about 3.2. The oxygen delivery is supposed to be around 600 cc per minute. And consumption is around 120 cc per minute, giving a ratio of 5:1. We all know that oxygen consumption is supply independent when the DO2 and when the DO2 VO2 is above the critical DO2. But when it drops to less than 2, the oxygen consumption becomes supply dependent with resultant lactic acidosis, multi-organ failure, and cardiovascular collapse. Hence, the goal of the ECMO is to maintain DO2 by VO2 ratio of equal to or more than 3. The beauty is that it allows safe DO2 VO2 ratio to be restored while avoiding harmful ventilator settings and vasoactive drugs. It itself does not fix your underlying etiology of heart and lung failure, but instead supports the patient by providing adequate DO2 while enabling time for diagnosis, interventions, and or recovery. Now, how do I know whether it is adequate or not? You have complex equations. We know how to calculate the total flow, oxygen content, then the consumption, then the DO2 VO2 ratios. Complex math. Let's just look at SCVO2 or pre-oxygen venous saturation. Can you tell me anything first? Let me tell you. Now, here in normal adults, we know that DO2 is about 15 cc per kg and oxygen consumption is about 3 cc per kg per minute in a normal resting metabolism. Now, what happens when the DO2 decreases down to somewhere around 8 over here at point B? You also look at the venous saturation. And normal is about 80%, 75 to 80%, where the DO2 ratios are about 4 or 5 to 1 around. Now, when the DO2 is going down, the venous saturations are also going down. Okay. Now, at this point of time, the saturations are 3:1, and the DO2 ratios over here are around 3:1. Over here, the oxygen consumption hasn't changed. But when it decreases to less than 3:1 to somewhere around 2:1, the venous sats are also decreased to about 50%. And at this point is where your endemic metabolism, lactate production, and shock occurs. Now, in some conditions, you can have an increased metabolism, increased oxygen consumption, but your cardiac output also goes up, increasing your DO2, DO2 to maintain the DO2 ratio of 5:1. That's your normal hypermetabolic phase. Now, what if my DO2 and VO2 is less than 3:1? Either you increase your DO2 or decrease your VO2. Before we go furthermore, let me tell you there is something called as an ECMO flow by cardiac output ratios. In a normal adult cardiac output, what we look at is the cardiac output of 5 liters per minute. Now, if you set your ECMO flows at around 3.5 liters per minute, that means about 1.5 liters is going through the least resistance conduit. Okay. So what happens in scenarios where my cardiac output goes up to 10 liters per minute and your flows are not changed? Now, here the ratio is about 3.5 by 5, that's about 0.7. Or here, when it increases and you have not changed it, the ECMO flow to cardiac output ratio goes down to 0.35. Does it have an impact? Let's see across. Now, for assuming a totally non-functional lung with shunt of 100%, and SCO2 of the orange line, the SCO2 of 75%, okay, with an ECMO blood flow to cardiac output ratio of 0.6, maintain the SATs about 90% with an FDO of 1. Okay. Now, over here, if my SCO2 drops down to 65%, okay, for me to increase the saturation to 90, I need to increase my ECMO flows so that the ratio should go up to 0.7. What happens, like in the prior scenario, when your cardiac output goes up and your ECMO cardiac output ratios goes to somewhere around 0.4. Now here, with the same SCO2 saturation, your ECMO flows to cardiac output ratios are about 0.4, labeling a SaO2 of around 85%. Now for me, either I have to increase the flows to get a ratio up and go to the 0.1, or I can use beta blockers. Now, what is with these beta blockers? Yeah, beta blockers are going to decrease your cardiac output, okay, thereby overall increasing the ratios, maintain the DO2. But it's a double-edged sword. The same time, when you decrease your cardiac output, your SCO2 is also going to come down, and you may land up with an SCO2 of 55%, invariably decreasing your SCO2. So you need to be careful. How do you need to use beta blockers, or where you need to use ECMO flows? Not only that, in a normal arterial bed with hemoglobin of 15, the arterial content is about 20 and venous content with 75% saturation is about 16. That means 1/5 of the oxygen content is consumed. We know this thing. Now, when your hemoglobin has been halved, the arterial oxygen content is lesser than the normal venous blood content. So that is the importance of hemoglobin, particularly in ECMO physiology or ECMO oxygen kinetics. So you need to maintain optimal hemoglobin to maintain optimal oxygen carrying capacity. Now, how do I monitor? There are various things that you monitor over here. All the things that are all the pressures and saturations that are monitored before the membrane are called the post membrane are called post, and in the body, the PO2 and the arterial and venous saturation. When you are using VA ECMO, you have 3 zones. One is the native lung zone, where the blood pumped from the native heart is going to carry up to. There is a mixing point because the membrane zone is going to, when the pump flows that are going to generate are going to supply up to this point. This is the mixing point. The importance of this we'll talk slowly down. In VV ECMO, when you have a femorojugular approach, so there is the drainage cannula, you have circuits, P venous or P1, and then you have centrifugal pump, then you have pre-membrane pressure monitoring thing, post-membrane, you have your thermometer and heat exchanger, you have your air blender gas inlet unit, and then from here, again, the circuits in the return calculator. This is the schematic diagram of your ECMO circuit in a VV. Now, let's look at the what all interactions of these extracorporeal circuit happens with the systemic. Now, the position of these cannulas. Now, where are you putting it? Is it femorojugular? Is it femoral? Is it single lumen cannulas, or is it double lumen cannula? Okay, is it a single stage cannula, or is it a multi-stage cannula? All these things do matter in calculating the recirculations, in calculating the flows. So if you're using a double lumen cannula, the lumen over here is a crescent-shaped lumen, which has got a 2/3 part for the drainage and 1/3 part for the return. And this return should always be directed towards the tricuspid valve to ensure an adequate drainage, adequate return. So as I told you across, this shape is mainly designed to optimize the pressure flow performance. So how do you select an adequate cannula? Because that is the most important determinant of flow. So first thing, what we need to maintain is what is the amount of cardiac output that I need to support. Say, suppose you want to support about 5 liters of cardiac output. Okay, so 5 liters of cardiac output. On the venous side, you look for a pressure drop that is created because of siphoning effect of the pump of about minus 50 mm, minus 40 to 50 mm. Over here is about 30 or 32 French around. On the arterial side, it's about 100 to 150. That's again over here is about 30 French. So 30 French double lumen, or if you see on this side, about 23 French single lumen, either single stage or multi stage cannula, is the ideal one to support up to 5 liters. We all know Poiseuille's equation has got a lot of importance, particularly in relation in determining the cannula size and length of the ECMO circuits, because the flow is proportional to the force powers of cannulas in a diameter as well, and inversely proportional to its length. So what you need is a wider diameter and a shorter length cannulas. Not only the cannula, even the tubing. If the tubing lengths are larger and diameters are smaller, it's going to add resistance to flow that will increase your pressures and will lead to complications. The heart of the ECMO circuit is your centrifugal pump, which generates a non-pulsatile flow. The main important feature is it is preload dependent and it is afterload sensitive. Okay, now how does this function? The RPMs drawn because of the revolution per minute, the blood is drawn by a negative siphon effect from the patient into the inlet of the centrifugal pump. The centrifugal force pushes the blood into the periphery and causes a pressure differential, which is how the pressure drop happens, and then spins the blood and exits it out. These are usually the radial flow pumps that are channel flow directed. Now, what is the application of whatever we have learned these things? If you have a decrease in P1, the access pressure, P1, P venous, okay, and extracorporeal blood flows, I mean, the pump flows are going down with a constant revolution per minute. Now, what you need to see is either you have a problem with cannular resistance or you have a problem with decreased venous access pressure. Okay, so you need to troubleshoot the causes. Even otherwise, you can have a decreased cardiac output causing this thing across. So that's where you need to troubleshoot. Now, till now, whatever the place, because of the negative suctioning effect, this zone is the negative pressure zone. So any disconnections over here is going to suck in air. So air in the circuit is a big problem if you have a disconnections before the pump, because it's a negative pressure zone. After the pump, it is a positive pressure. The pump is going to generate a positive pressure and then push it up. So any disconnection over here can cause catastrophic blood loss. Coming to the membranes, when the blood flows in this phase, the membrane is over here, and then the oxygenator. This is how it used to be, and the gas flows in a laminar way. So because of this, there is something called the boundary layer effect, where the RPCs which are close to these boundaries are well oxygenated, and RPCs that are far off are not well oxygenated. The problem doesn't exist for carbon dioxide though. To overcome this one, they came up with the concept of hollow fiber concept, where the gas flows within the hollow fibers and they are arranged in bundles. Okay, they are made of polypropylene, and you have a heat exchanger unit through which the water flows around. They are made of polyurethane. Now they are arranged in overlap layers of woven stacks perpendicular to each other, allowing a diffuse good oxygenation, no boundary layer effect, because this is going to disturb your laminar flow. Another important concept in your membrane is a rated flow. Now, at a in a patient with a hemoglobin of about 12 and which is 70% saturated in the venous side, the arterial oxygen content is about 11 cc per deciliter. At low flows, when it goes at the outlet, the pivot is going to be good. So the outlet oxygenation is about 100% saturated. At this point, the oxygen content will be around 16 cc per deciliter. So inlet and outlet difference is about 5 cc per deciliter. But when the flow is increasing, initially the oxygenation increases, but slowly at one point it starts decreasing. Okay, you're able to see that. The reason behind is because of increased fees, not the increased fast, not that all the RBCs are getting oxygenated over here. So you will have a drop in oxygenation. Now, once the flow at which the outlet saturation is around 95%, it is designated as the rated flow of that device. So when the blood flow increases above the rated flow, the arterial oxygen delivery doesn't increase. In this one, if you look at above the 3 liters, the actual oxygen delivery is fixed at 150 cc per deciliter, 150 cc per minute. How do I know whether my membrane is working or not? You can look at the pre and post membranes, the difference between the pressures. You can also look at the gas transfer and also look at the hematological profile. Any abnormalities in these things across may suggest membrane lung dysfunction. So you need to think of circuit change. Now, during the VV ECMO, the mechanical ventilation should ideally keep the alveoli open, thus reducing the native lung shunt and avoiding alveolar overdistension, thereby minimizing the lung injury and the dead space. Overall, this is a system in which the ECMO, native lung, and the mechanical ventilation are interdependent. To understand this well, a figure of 8 has been suggested. Now here, because of the diseased lung, you have a low lung volumes, so increase the dead space, decrease the efficiency of clearing your ventilation, so increase the inlet carbon dioxide, which increase the efficiency of the membrane lung as the gradient of the carbon dioxide diffusion into the sweep gas will increase, thereby decreasing the mixed venous carbon dioxide, again leading to decreased efficiency of carbon dioxide removal from the lung. So in turn, the ECMO usage is going to be better because of low lung volumes or ultra low productive ventilation, and vice versa. Not only that, because of decreased respiratory rate and tidal volume, your decreased mean airway pressures and pleural pressures, your mechanical power is going to come down. So thereby decreasing your risk of VLE. Coming to the cardiac physiology, we all know the pressure volume curves. I mean, this is stroke work, potential energy, arterial elastance, and the ventricular elastance. The ventricular arterial coupling can be expressed by a ratio of EA by ES. Normally, the reference is around 1. Now, what happens in heart failure? The curve gets shifted down and to the right. Now, here, when you start with an ECMO, the stroke work decreases, and when you increase the ECMO flows, the stroke work is going to come down. So it becomes narrow. Because of ECMO, you have a decreased LV and diastolic pressure and volumes, as well as LV stroke work. Okay, whereas increased arterial elastance, because it increases the afterload, and the EA by ES ratio is also increased. So that's the physiology of how an ECMO is going to help in your heart failure. Now, how do you know whether your ECMO is increasing, your ECMO flows are benefiting you or not? You just look at the pulse of, the arterial trace. If your arterial trace and magnitude are pretty good, that shows that you have an increased LV contractility, increased aortic compliance, increased peripheral resistance, and increased flows. Extracorporeal circuit in way is a double-edged sword. On one side, it can generate reactive oxygen speeds, endotoxemia, a dysregulation of the inflammatory cascades leading to increased systemic inflammation. On the other side, by facilitating lung protective ventilation or giving myocardial rest, improving the organ perfusion and decrease VD, decreases systemic inflammation. Particularly VA, ECMO, and lung, because of the failing heart, the LV stroke volume is decreasing, increase the LV or LA pressures, and increase the pulmonary venous pressure. You have a hypoxemia, pulmonary edema feature. Not only that, it carries forward backward, leading to increased pulmonary arterial pressure. Since you're draining the entire fluid from the entire venous component from the drainage canal, the RV is also not filled. This may lead to pulmonary fibrosis and neoangiogenesis on a longer run. We all know the coating surface can, because of the plastic surfaces, the contact activation can cause clotting activity. I'll just tell you in the next step. Now here, I told you about these three lung zones, right? The native lung zone, mixing point, and membrane lung zone. Now here, when your LV is improving but your lung is failing at first, the deoxygenated blood is going to get distributed mainly into the head part. This is called something called as the North-South syndrome or differential hypoxemia or Harlequin syndrome. Or here, what you need to do is add another return cannula into the jugular so that the oxygenated blood gets pumped up, and you need to wait for the heart to recover. What happens if my ECMO flows are less? Are higher than the low native cardiopulmonary flows. So your flows are high, there is a stasis in the heart and the initial part of the circuit. So there is an increased risk of stroke because of stasis. When your flows are equal, there is a decreased risk of stroke. So this is what we spoke about. The artificial surface of the ECMO, the contact system activates the calculin and bradykinin mediated intrinsic pathway, as well as because of inflammatory cytokines, the extrinsic pathway also gets activated, leading to stimulation and production of thrombin and thrombus formation. This is the reason why you need anticoagulation when you are on ECMO. So coming to the take home, VA ECMO can increase afterload. So you need to keep looking whether there's an LV distension, how is my aortic valve, is it opening or not? Is the patient having pulmonary edema? Do I need to unload? What should be my canalization? Not only that, it is flow limited. So you need to see what's happening to my venous return function. Do I need to increase the main systemic filling pressures, or is there any resistance to the venous return? Because of opposing circuits, you can have differential hypoxemia, Harlequin and Northcott. So you need to look at your canalization strategy. Since the lungs are not majorly involved in the gas exchange process, you need to closely monitor the lung function as well as watch for lung deterioration. In the VV ECMO is going to reduce your RV failure. That's going to be important. But because both the canulas are in the venous phase, there is chances for venous admixture and desaturation and because of recirculation. So you need to keep a close watch. Not only that, you also need to look at how the cardiac output changing, how the ECMO flows to the cardiac output ratios are there, so that you need to match the flows to maintain an adequate oxygen saturation. Since the artificial lung is going to do the CO2 elimination, it limits the ventilator-induced lung injury. Not only that, it also decreases your alveolar overdistension barotrauma, thereby limiting the mechanical power, making VV ECMO to improve the native lung. Thank you.